Yes, sir.
Mahisha?
Yeah.
My theatre assistant Raju is there.
No, we have some technical issues here.
The term I had told him to bring 3 term sets, which I think.
Because this is what happens when you start endoscopy in a new place. A lot of things, even if we,
No, he has brought a few term sets, which will be, I think, useful.
things may not be there. So, we are trying to get this fixed on. ಅದು ಯೂರಾಲಜಿಯದ್ದು ಇದಿಲ್ವಾ ವೈಕಲ್ ಅಂತ ನಾನು ನಿನ್ನೆ ಹೇಳಿದ್ದೆ I have told everything what is required. Okay. So anyway, I hope on ಮಾಡಿ
Irrigation on.
So let us see if it. Did you get the full switch?
Off, please.
No, it is not going to stay.
Mahisha, ಅಲ್ಲಿ ರಾಜು ಅಂತ ಇರ್ತಾನೆ.
The problem is we don't have a connector. No, ಅದೇ ಬೇಕಾದ್ದು.
Open ಮಾಡಿ.
Sir, there is a PORP connector available in the OT for irrigation.
Yeah, that's what they have, but it was kept somewhere else. So it is there. No problem. Recording. That's a full switch, man. That's a full switch. Full switch. Full switch. Full switch ಏನಾಯ್ತಪ್ಪ ಫಸ್ಟ್ ಇದು
ಇಲ್ಲಿದೆ ಸರ್.
ಇದೆ ಅಪ್ಪ ಇರುತ್ತೆ. Okay. And then bucket is ready. So I hope you can see the picture inside now.
Yes, sir.
Now the grasp of So once we go inside, we will see only the muscle covering.
Can you please reorient us, sir?
So we just have to remove this muscle. Okay. Of course, we.
Yes, sir.
We is there. So once we clear this soft tissue, sometimes there will be bleeding like this here. So actually we have a monopolar system also, but unfortunately we don't have a foot switch here. And the foot switch production small one.
Mahisha, can you hear me?
Yeah.
Yeah, Raju is there. He has brought that RF also, 4 megahertz.
Other than foot switch, yeah, we have things. So this is RF machine, which I am using. But the problem is it will be slow. It won't be fast. If you have a monopolar which is working, it will be very fast. Luckily there is not much bleeding happens now.
Can you please orient us, sir? Medial lateral.
So this is the interlaminar window here, which is covered with some muscle tissue. So you can see that I am tilting my scope quarterly. Monopolar fixing ಏನಾಯ್ತಪ್ಪ?
Mahisha, there is a request that you need to slow down your surgery because.
ಫುಟ್ ಸ್ವಿಚ್ ಏನಾಗಿಲ್ವಾ? ಫುಟ್ ಸ್ವಿಚ್ ಇರುತ್ತೆ ಸೈಡಲ್ಲಿ ಇಟ್ಟಿರ್ಬೇಕು. ಫುಟ್ ಸ್ವಿಚ್ ಬರುತ್ತೆ. So if you have a monopolar working, this job you can finish in 5 minutes. But unfortunately they don't have a foot switch here. So it will take longer time. And then better the battery there. Okay. So I'm just cleaning the soft tissue from the interlaminar window. It made it light up for there. that I hope you can see the picture down there. Hello?
Yes,
Yeah,
sir, we
yes,
can,
yes.
we can figure it.
Picture is clear?
Yes,
Yeah.
it's clear.
Okay. Give me other. So this is the Interlaminar window here with the playarm here. Of course, these steps it will take long time with the RF machine. I got all the monopolar probe and cable, but monopolar foot switch is not. So can you see the edge of the lamina here?
Yes, sir.
Okay. So this is the pars area here. I'll show you the pars. So this is a very important bony lamina. The pars. So here you get a vessel which is a direct branch of aorta. So the radicular artery comes here. So sometimes it can bleed heavily. So that's why neurosurgeons will tell never go lateral to the pars. So I was fortunate to be trained with a neurosurgeon during my fellowship. Normally orthopedic people will not get a chance to work with neurosurgeons. So if you work with neurosurgery, you will get some patients. Because orthopedicians are not having enough patients. Work out ಅದು ಆಫ್ ಆಗಿದೆ ನೋಡಪ್ಪ ಪಾರ್ಟಿ ಆಫ್ ಆಗಿದೆ
This one.
When you are working outside the lamina, do you keep the pressure at high level?
So
Sorry,
this is
pressure
the
at high
part.
level.
Can you see the part?
Yes.
This is the part. Can you see?
Yes, sir. Yes, sir. We can see.
Yeah. This is a very important landmark. Whether you do decompression or fusion or whatever.
Mahesh, Dr. Shastri here.
Yeah.
For the sake of postgraduates, can you orient them so that?
Yeah. So in this view, if you see 9 o'clock it is cranial, 12 o'clock is medial, 3 o'clock is caudal, and 6 o'clock is lateral. So this is the orientation. So this is the interlaminar window here. Working with RF will take a long time. Whereas a monopolar it will be very fast, but I am not able to show. This is the caudal lamina. Can you see here?
Yes, yes.
This is the caudal lamina here down. With monopolar you can take it out very, very fast. With RF it will be very slow. So this is the interlaminar window with the playoff, and down you have the L5 lamina. Okay? So is it clear?
Yes, sir. It's clear.
Give me clear. So this is the curate. This is the curate. So this is a curate which is very useful. This again is designed by me. So it is helpful in removing all the soft tissues, releasing the playoff. So all these steps in gets and gets. So most important thing is gets. You have to clear the soft tissues before you do anything, and also the field has to be flattened. Otherwise you cannot start the process. So if the field is flattened, then you cannot go. This is the interlaminar area where I am working now. So this is the interlaminar window, that is the playoff, this is the edge of the lamina, and this is the part. Is it clear?
It is clear, sir.
So, and the facet joint is here. This is the facet capsule. Can you see? This is the facet capsule. Okay. So medial is the spinous process. Now we are ready to drill. So I am using a 5 mm burr. Okay. So it's a cutting bar. So we start drilling. So we have garrisons also, but garrisons should not be used initially because the garrisons are, these are tubular garrisons, not like open surgery garrisons. So they are not very strong enough to take out the full bite of the bone. So what we have to do is we have to thin out the bone and then use the garrison. Clean. Hey, this is art activity. This art activity. What will come on my that is the great amount we make it. So this burr will remove some tissues which is coming in the way. Nice to the cut. Sharp edge anything. Still not used. So this is a cutting burr, you can see the cutting edges. So one important question is how much to drill. How do you decide how much you have to drill? So there are two ways. Either it can come from below up or it can come from top to bottom. So I generally start at the spinolaminar junction and then go laterally. But you can do from below upward. You can expose the tip of the facet and start drilling and then come up. So that's also possible.
What is the upper limit of
the upper limit is the insertion of the flavor. So generally it is at the level of the parts. So that's why parts have to be exposed. Very important. So there is some tissue coming in the way. All these soft tissues would have been cleared if I had a good monopolar. But we don't have.
Can you give us some safety tips for using this cutting burr?
I did not get the question.
Some safety tips about using the burr.
Initially you should not use cutting burr. You should start with a diamond or oval burr, which is much safer because these burrs, even if you go inside, nothing will happen. Whereas cutting burr, it is very fast but dangerous. You can see here, this is the path. So this is my burr, which is about 5 millimeters. So I have enough bone which is required for the stability of the spine. Okay?
Okay.
So now my upper limit is still here, I have to drill. This is the path. The confirmation is once you expose the flavor, you will see the insertion of the flavor. Once you release the insertion, then it is fine. The cranial extent is enough.
If you watch Dr. Magesh's hand, so
I am carrying some tissues with the burr.
So it is not fixed. He is using the scope to angulate the drill and he is not angulating the drill per se. Because it's a fine drill, if you try to angulate with the drill can break.
Brother, you should hold grasp. I require grasp for you. Can you see the anatomy? Hello?
Yes sir, we can
I
see.
think mic is soft, okay?
Yes, we can see that. Can you hear us sir? Hello?
Mic is not.
I can not okay.
Can you hear us sir?
Mic is.
Can you hear us?
Yes. Light ಏನು ಆಫ್ ಮಾಡಬೇಕು ಆನ್ ಮಾಡಬೇಕು ಮಾಡಿ ತೊಂದರೆ ಇಲ್ಲ ಮಾಡಿ ಬಟ್ ದಿಸ್ ಗಿವ್ ಮಿ ದ ಓವರ್ ಬರ್ತದೆ
Mic, kindly switch on the mic. Santosh ಎಲ್ಲಿದ್ದಾರೆ? Santosh.
Can you hear me?
We can hear you sir. Can you hear us sir?
ಸಂತೋಷ್ ಎಲ್ಲಿದ್ದಾರೆ? ಬ್ರದರ್ ಸರ್ ಮೈಕ್ ಆನ್ ಮಾಡುತ್ತೆ
because I don't see very well.
Can you hear us now, sir?
I hope you can see at least the video. So now I will switch over to oval birth. This is a much safer birth. So even if I go inside the canal with this birth, nothing will happen. So I will switch to oval birth. You can see the edges of this birth are not very sharp.
Grasper. Grasper. Pause please.
Sir,
Mic is not. Hello?
sir, can you hear us?
They can hear.
He can't hear them.
No, we can't hear. We can't hear them. Hello?
We can hear you, sir.
Kindly check for input of audio to OT.
Masha, can you hear us?
Input of audio to OT is not there. Check.
Masha, can you hear us? Hello?
Hey, brother, kaya akta. Food situation go. ठीक है हाँ अरे क्या करेंगे
what Masha has done is he has burned the lamina, the inferior edge of the lamina, so up to the pars, because the extent of the ligamentum flavum is up to the level of the pars. So,
okay, anyway, I will continue.
So we use a different burr, a cutting burr for the upper.
Sorry, so I am continuing drilling. So this is the facet which I am drilling now.
So it's going more
This
lateral.
is the facet. So I hope you can see. So I switch to oval burr. The facet I am drilling now. You can see the edge of the facet here. And this is the spinal laminar dimension.
Hello.
Yes. Intermittently it is working.
Can you hear us, sir?
Yeah. Now I can hear.
Yes, sir. So they want to know more about the conical burrs, about the height, diameter.
This is 4 mm diameter, and the height of this burr is 6 mm. And if you see the edge, it is not very sharp. So it will drill a little bit slower, but the advantage is it's very safe for the dura. Nothing will happen to the dura. Even if I go inside the canal through the flavum, it will not damage the dura. I have done it multiple times. So that's why I am using it now. So I don't use the cutting burr. Other burr we have is the diamond burr, which is also good. You can use diamond burr also. The initial burr was 5 mm, this is a 4 mm burr. So here a very thick lamina. So can you see the flavum deep?
Yes.
So that is the flavum, this is the bone, this is the part. So we go a little more here. So we have developed curate osteotome so that all this work is very easy to do. I will show you how we can use the osteotome. We require osteotome when we do extrusion because if you use burr, you will not get any bone for interbody graft. So that time we use osteotome. So that is our cranial extent. So we are yet to see the insertion of the flavum. Can you use osteotome? So now I use osteotome. It will make very faster. Okay, take the hammer. So this is the osteotome. I will go here. Okay, click, nothing but go. So you can see the leeway. So once it is gone through, you can have the leeway when you give the grasp. So this is part of the first step which we have osteotomized. Of course, we remove very little bit of the facet, not too much. No way it is going to affect stability. It will be much less than the amount of bone which you remove in open surgery. Because it is a big piece of bone, you have to remove the dilator. So I took out through the camera. So I put the camera again. Okay. So now we go inside. Okay. So this is another piece of bone which is here. I will take it out. So still some more bone is to be removed here.
Right now we are seeing the facet of the clear block position, because if you watch it, Dr. Mahesh on that, is rotating the camera to get a different orientation of the target.
So we have removed part of the facet with the osteotome, and we are going inside now again. So so this is our bone work. I will show you how much we have removed here. This much we have removed here. And I will release this layout from here. This is the interior insertion that is to the L5 axis. Okay, sir? Or transfer. 7. Connect to another 7. Connect another one. And replace this with another one. And put adrenaline. So we use adrenaline for each bottle of irrigation. So that will help in controlling the bleed.
What is the dosage, sir?
1 ampule for 3 liters. Okay, sir? Okay. 1 ampule for 3 liters. Okay. So that helps in controlling the bleeding a lot. Okay, sir? Okay. Big one. So because we are generally under spinal anesthesia, we need hemostasis. We don't do so much of hypotension. Okay. This is a superficial layer of flavor which I removed. Can you see now the deeper layer?
Yes, sir.
The superficial layer I have released now from interior. This is a deeper layer. So already you see the midline the flame got split and open. Okay. This is the lower edge. Can you see the L5 superior edge? Can you see?
Yes, we can see that.
Okay. So now I will take the Garrison and release the lower insertion. This is the Garrison. You see here I am going below the laminar. You can use burr also. You can use burr or gauge, whatever.
हे शारदे दय पालिसु ಈ ಬಾಳನು ಬೆಳಕಾಗಿಸು ನಾಳೆಗಳ ದಾರಿಯಲಿ ನಂಬಿಕೆಯ ನೆಲೆಯಾಗಿರಿಸು, ಮುನ್ನಡೆಸು, ಕೈ ಹಿಡಿದು ನಾವಾಡೋ ಪದ ಪದದಲ್ಲೂ ಸಂಚರಿಸ. ಭೂಮಿ ತಂತಾನೆ ನಡೆಯುತ್ತೆ ಸ್ವಾಮಿ, ಪಾಲಿಗೆ ಬಂದಂತ ಪಾತ್ರನ ಎಲ್ಲರೂ ಜೀವಂತಿಸಿ. ಹೇ ಶಾರದೆ ದಯ ಪಾಲಿಸು, ಈ ಬಾಳನು ಬೆಳಕಾಗಿಸು. ಹೇ ಶಾರದೆ.
I request Dr. Mahesh sir to kindly join us on the dais.
ವಿವೇಕಾನಂದರ್ ಅವರು ಹೇಳಿದ್ರು ಈ ದೇಶ. ಸೊ ಅದೇ ಪ್ರಿನ್ಸಿಪಲ್ ನಾವು ನಮ್ಮ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ಆಫ್ ಆರ್ಥೋಪೆಡಿಕ್ಸ್, ನಾನು ಮೃತ್ಯುಂಜಯ ಸರ್ ಅವರೆಲ್ಲ. ಇನ್ನೊಂದು ಎರಡನೇದು ಒಗ್ಗಟ್ಟಿನಲ್ಲಿ ಬಲವಿದೆ ಅಂತ ತೋರಿಸೋದಕ್ಕೆ ನಾವು ಚಾಮರಾಜನಗರ ಇನ್ಸ್ಟಿಟ್ಯೂಟ್ ಆಫ್ ಮೆಡಿಕಲ್ ಸೈನ್ಸಸ್, ಚಾಮರಾಜನಗರ ಇನ್ಸ್ಟಿಟ್ಯೂಟ್ ಆಫ್ ಮೆಡಿಕಲ್ ಸೈನ್ಸ್, ಟೀಚರ್ಸ್ ಅಸೋಸಿಯೇಷನ್, KGMYA ಆ್ಯಂಡ್ ಇಂಡಿಯನ್ ಮೆಡಿಕಲ್ ಅಸೋಸಿಯೇಷನ್ ಚಾಮರಾಜನಗರ, ಹೆಲ್ತ್ ಆ್ಯಂಡ್ ಫ್ಯಾಮಿಲಿ ವೆಲ್ಫೇರ್ ಡಿಪಾರ್ಟ್ಮೆಂಟ್, ಆಮೇಲೆ ಚಾಮರಾಜನಗರ ಆರ್ಥೋಪೆಡಿಕ್ ಅಸೋಸಿಯೇಷನ್, ಮೈಸೂರು ಆರ್ಥೋಪೆಡಿಕ್. ಟ್ಯಾಲೆಂಟ್ ಇದೆಯಾ ನಾವು ಹುಡ್ಕೋಣ ಅಂತ ಫಸ್ಟ್ ಟೈಮ್ ಎಕ್ಸ್ಪೆರಿಮೆಂಟ್ ಮಾಡಿದ್ವಿ. ತುಂಬ ಚೆನ್ನಾಗಿ ಸೌಂಡ್ ಸಿಸ್ಟಮ್ ಮತ್ತು ಆಡಿಯೋ ಸಿಸ್ಟಮ್ ಅವ್ರು ಮಾಡಿದ್ರು. ನಾನು ತುಂಬ ಅಪ್ರಿಷಿಯೇಟ್ ಮಾಡ್ತಾ ಇದ್ದೀನಿ ಅವರಿಗೆ. ಊಟದ ವ್ಯವಸ್ಥೆಯಲ್ಲೂ ಅಷ್ಟೇ ಬ್ಯಾಂಗ್ಳೂರು ಪುಳಿಯೋಗರೆ ಅವಸರು ಕಾನ್ಸ್ಟೆಂಟ್ ನಮ್ಗೆ ಸಪೋರ್ಟ್ ಕೊಡ್ತಾರೆ ಕ್ವಾಲಿಟಿ ಫುಡ್ ಕೊಡೋದಲ್ಲಿ. ಅವ್ರಿಗೂ ಒಂದು ಚಪ್ಪಾಳೆ. ಸೊ ಈ ಅಮೃತ ಕಲಶ ಜನರಿಗೆಲ್ಲ ಸಾಕಷ್ಟು ರೀತಿಯಲ್ಲಿ ಹೆಲ್ಪ್ ಆಗ್ತಿದೆ. ಮೊದಲು ರೆಫರಲ್.
Yes sir, if you can tell us the orientation, then it will be nice. Or if you can show the X-ray if possible, or the CT, MRI, whatever it is, imaging, whatever.
Camera. Can you show the
Correct, display the video. Correct. Correct, display the patient details.
So I believe they have presented the case in the hall.
No sir, no.
Correct.
If you can tell orally, no problem.
Okay.
Briefly tell us.
Okay. So this is the patient with the no back pain radiating to the left lower limb, not associated with conservative management. And MRI shows. So here we need to go at the disc level. If we look at the sagittal images, the disc is just at the disc level. And in the axial images, the disc is at the left paracentral region. Then AP view is very important process for the bony window. You can see this CM image, AP view showing AP view. If you look at the L4S1 space, there is adequate space, interlaminar window. Whereas if you look at L4-5, it's enough but not so adequate. So that determines whether we need to drill the wound, drill the lamina, or we just have to phlebotomy and proceed. So confirming the level should be done in the AP view. Can we have the CM? So, as already we have discussed, ergonomics is very important in endoscopic surgery. So, if you are operating on the left side of the patient, you keep the monitor on the right side, on the foot end. If you are operating on the right side of the patient, you keep the monitor on the head end of the patient. Then you can avoid neck pain by placing the monitor properly. So, we feel for the iliac crust usually corresponds to L4 L5 disc space. Adjusted level below is the L5 S1. And if you palpate deeply, you can feel the spinous process on the interspinous space. So keep your dilator just 5 mm away from the midline towards you and take an AP shoot. So for this, the CM should be vertical. We don't need to get optimal view because we need to work vertical. So we are at a L5 lamina. I want to go a little bit down. Shoot. Okay. So we are in the L5 S1 interlaminar space on the left side, just a few millimeters away from the midline. So I just mark this place. I usually give a lignocaine with adrenaline mixture, 5 ml on the incision site. also in the muscle pain, a little bit in the muscle too. I'll give a few seconds for the adrenaline to act. And it is safer to remove part of this plastic tray because in invasive surgery there are reports. Most surgical infection is associated with retention of this plastic material in the surgical field. No need to remove this much, we can remove that. Fine. So we take an 8 mm incision. So planning this incision, if you want to work on up-migrated disc, you plan the incision slightly lower, so you can angulate the scope caudally and cranially. And if you want to work on down-migrated disc, angulate the scope, plan the incision slightly superiorly. Here we are just going to work at the level of the disc. 8 cm incision, thin incision, and then you have to open up the fascia. So initially, we may find it difficult to know whether we are cutting a fascia, we have advanced insight. There is a chance of a flavum injury. But if you feel for the resistance while going in, you can't be wrong.
It's a transverse incision or a vertical incision?
It's a vertical incision.
And we are seeing a little hyperlordotic spine.
It was much more lordotic, sir. We have obliterated all of this by placing some soft notes below the ASIS. Now the dissector is inside. And we have to, either we can land directly on the flavum and feel for the softness, or you can land slightly superiorly on the lamina and then come down into the interlaminar window. Then again injection. Shoot. Okay. So we are on the interlaminar space of L5S1. So since I can feel the softness and I think I have landed over the flavum, in the lateral view, the tip of this dilator should be slightly anterior to the pathogen, descending pathogen. Let's check in the lateral view. No. Table up or came pull down. Matthew. Can you get the camera?
Can you see the CM picture there?
Right, we are getting the image, sir. Shoot. Not us. Produce the right foot.
Kirti, you can turn the CM like this one, so that it can go down a little bit and the level.
No, you can just increase, get them put it up.
Yeah, you can rotate the CM.
No, go down. Just go down, go down. So you get the level. Okay. Yeah. Okay. So we can see here, we are just anterior to the father joint, and we are at the level of the inferior end plate. Level of the inferior end plate. Can you please show the previous image?
If you have slipped the tip of the inferior part of the lamina, or you directly landed on the.
I have landed on the lamina of L5.
Okay.
And slide it down and landed on the plane.
Okay.
So if you look there at the AP view and lateral view, AP view we have space outside, and in the lateral view we know we are at the inferior end plate level, and the disc is at the level of the disc. So we don't have to do much of bony work in this patient. We can proceed with the phlebotomy. CMO. No, just leg it down. No, come on. Head and down. I mean, head and down. Okay. Okay. So this is our revolved sleeve. So it can be inserted in two ways. Initially we have to work with the medial part facing medially, and then we have to, once we are inside the canal, we can use this bevel as a dissector to retract the root. Okay. If we can go in with the bevel facing medially, or we can go in with the bevel facing laterally. If we go laterally, this can be used as a dissector. This can dissect the muscle on the medial aspect. And then once you are in, you can rotate the bevel laterally. The bevel should be facing medially now. I mean the open end should be facing medially.
The scope degree is 30 degrees or 0 degrees?
Sorry, the
Scope.
The
angle of the scope. 0 degree angle. It's a 0 degree.
25 degrees. This is 25 degrees. So now we see the muscles here. Use a punch to remove some of the muscles so that we can see the flame clearly. Punch. Cutter. I need a punch. Straight punch. So basically we need the three instruments. This is a straight punch, like our pituitary Roger. Then we need a cutter. This is a forward punch. Then this cutter. So this cutter is used for cutting the phlegm and also for cutting the animals once we are inside. So with the punch, just remove the muscles of the phlegm. So 6 o'clock is lateral, 12 o'clock is medial, 3 o'clock is caudal, and 9 o'clock is cranial. we don't have to remove each part of the muscle outside. We can just keep the punch inside and remove smaller parts, then get washed away with the saline. That saves time. So this is what we worry about the endoscopy surgery. There is a sudden gush of blood, then we may lose vision, we cannot see the bleeder. In that case, you just inside, smoke inside, close to the bleeder. So now the direct force of the saline is over the bleeder, so the bleeding will reduce and we can see where it is bleeding, and that's controlled with our arm. It is very important to get adequate hemostasis at this step. So once we open the flavum, we can concentrate more on the neural structures. RF can be used for shrinking the soft tissue as well as to achieve hemostasis.
So pardon sir, can just reorient us again about the caudal and
Sure.
cranial.
So
Medial and lateral.
9 o'clock is cranial end, 3 o'clock is caudal end, 12 o'clock is medial, and 6 o'clock is lateral. So here you can see the medial bone of the facet. This is the facet. You can see the facet here. This is the inferior bone of L5 lamina. Can you see the shiny capsule here? Touching with the
we can appreciate it. Yeah.
That's it, sir.
Now you just keep the bevel, push the sharp end of the bevel inside, and can you see the pressure on the flavum? I'm putting a lot of pressure on the flavum. So we need to keep the flavum taut, and it's very important. It's very important to keep the camera oriented. You see the camera marker at 6 o'clock position. We should keep an eye on that frequency because while handling the smoke, sometimes the camera angulation may vary. So if the marker is not at 6 o'clock, just clear some more soft tissue. Can you see the orientation of the flavum fibers? They are longitudinally oriented from cranial to caudal. So we are going to cut transverse to the orientation of the fibers. But now if you rotate it, then the orientation changes. Now we are seeing the opening part of the scissor, cutter. But if you keep the smoke like this, please look at my hand. If we keep the smoke like this, we cannot see what we are cutting. Just rotate it 90 degrees, then we see what we are cutting. Just put the cutter inside, with the cutter dissect along the longitudinal fibers of the flavum, then take it bite. Okay, sir, either we can continue with the cutter or you can use an up cutter. And it's very important to see what we are cutting.
What's the epidural fat that is coming out?
Epidural fat is coming out. So you can remove a little bit of the fat so you can visualize the neural structures properly.
Okay, go ahead.
Now we will have the doubt whether we are seeing the root or the flame, neuron sac. So it is very important to see the lateral bone of the root and make sure that there is nothing lateral to where we are looking. Sometimes we may be working on the axil of the root and we may be damaging the root with the bugle, the sharp end of the bugle.
Sir, so you are dissecting more towards the lateral and inferior side. So it has to keep the root.
Yes, it's very important. And also, we have a tendency to keep the root retracted for a long time. And it's a good practice to keep a timer below your monitor actually. Some studies have come forward to say that it's better to release the nerve every 6 weeks once, 6 minutes once. So if you are working for a long time in this place, we have to just rotate the sleeve once. I can see a bunch here. Cut up. Yeah. So there is no armor defect, it's a contained disc. So what we need to do is we have to use an arm motor to make a rent. Or we can use the cutter.
So keeping the scope a little backwards so that you can see the tip of the isomorphous retracting the root.
Sure.
Yeah.
Okay, can you see the tip of the bugle?
Yeah.
So with the arm motor, we'll make it cut. Like a 2-shade incision. The arm motor is a sharp thing. Make sure your dura is protected well and the root is protected well.
Not adequately mobile.
Yes, sir, welcome, sir.
Yeah. So anyway, I am leaving, so I thought I would tell you this. All the best.
Thank you, sir.
Okay.
Operating position. Now if you look at the lateral aspect there. Now you fitting to 10th is fitting to.
Okay.
Can I replace the question? Can we place subcutaneous part over the neuro? Is that the question?
Where it is long time steroid and fat as atrophy. Fat as atrophy. Some subcutaneous fat, some surgeons place it.
So if you place a small amount of fat, we use the fat patch in case of pleural tap in open surgery. We can plug it with the subcutaneous fat. But that is avascular fat. So that can go in for necrosis. And if you use a large amount of fat, then there can be a source of infection. Currently there is a study in our institute where we are working with plastic surgeons.
Thank you once again, sir, from Department of Orthopaedics and Chamarajanagara Institute of Medical Sciences, from coming from all the way from Chennai and giving support for this CME live demonstration program.
Thank you, sir. Now can you see the flame here? So in the interlaminar window, we have removed only hardly some 30-40% of the flame from the lateral aspect. So the cord is, the neural tract is nicely safeguarded by the flame here. And when we come outside, we can see the muscles falling apart nicely. So we have not even damaged a single muscle fiber. Thank you for the opportunity, sir.
Thank you, sir, and please give a round of applause to the So you can hear the round of applause. Thank you, sir.
Thank you.
I want to thank Department of Anesthesia and OT nursing staff, medical assistant for arranging all these things for us, and Auditorium by our nursing superintendent on behalf of our Department of Orthopaedics. Move on to next surgery, that is Transforaminal endoscopy discectomy. From today morning we had a demonstration of the interlaminar decompression. Now interlaminar decompression with discectomy. Next case will be transforaminal discectomy, which will be done by Dr. Rajiv sir from Vrindavan Hospital, Mysore. Those who are interested, you can attend. there is a free registration, and they accept it for the free transportation. So we can go. We can learn robotic surgery in spine also. Next step for the spine surgery. Thank you all. And update and upgrade yourself. Thank you very much.
We had a claudication distance of around 500 meters and no known comorbidities. On examination,
Thank you.
So we are one and we are united. We want to show the unity. Second, the unity among the doctors in orthopedics fraternity. That is the Chamarajanagar Orthopaedic Association, Mysore Orthopaedic Association, Karnataka Orthopaedic Association. Everyone appreciated and contributed for this program. I want to thank all the associations, and we want the same kind of support for the future programs in our institute. Thank you all. Friends in our institute. Thank you all.
So this is a high iliac crest. So what I do is I keep it in position, but then shift the sternum pin a little above so that it clears the iliac crest. Shoot. Okay. This is more. Shoot. That should be enough. So I am marking this line. We usually mark the spinous process line, this line, the AP line, as well as the lateral line to cut the lordosis. But then I think we are a little running late, so I go ahead with starting the surgery. Scale, yeah, not scale, yeah. Okay. Our entry point is usually 9 to 11 centimeters from the midline in the AP view, usually around 11, because we want to be more epidural. So this needle, it's marked every 1 centimeters, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 and 11. So this is around 11 centimeters from the midline. So our entry point is going to be from here. Local please. Local, Jalkin. 2% Jalkin. Plain. So one more point to remember is, you can see the flat of the back. Now where the flat of the back turns into the abdomen, that is the junction. You should not be going anterior to that. So that is the point from where we make the entry point. Because if you enter below that, then there is a chance that you can pierce the peritoneum and you can enter with the intestines. So it should always be level above the level of this transition from the back to the abdomen. Yeah, local please. Itu apa? Proses seperti itu, masuk dalam bisa berkata. Jangan cabutin. Okay. Sometimes you can focus on his face also, that he is conscious. Yeah. Local. Sorry.
What is the dose and any adrenaline is mixed with that or 2% or 1%?
This 2% Zalakate, just plain Zalakate. Yeah, direction of the needle is towards the facet joint. Facet joint of L4, L5.
Will it transfers or parallel to the ground?
I am unable to hear, sir.
Is it transverse or parallel to the line?
Ground.
No, it is at an angle of around 25 degrees to the surface, the posterior surface of the body of the patient. The focus is. So you can see the needle here, this is around 25 degrees. Crane 25 degrees. So you can see the lateral view. You are seeing the lateral view that we are hitting the facet there. So what I do is I withdraw the needle here. Can shift it down. Take it down. Yeah. ಸ್ವಲ್ಪ. Shift ಮಾಡಿ. Always repeat that we don't bend the guide wire. Shoot. You can observe that now. Now I am sitting on the facet. Shoot. I am touching the facet and now I push the dilator under the facet. Shoot. Okay. Shoot. So now we are in the middle pedicle line. Now take a lateral view. And then take out the guide wire. ಶಾಬುದಿನವರೇ ಈಗ ಸ್ವಲ್ಪ ಸೊಂಟದಲ್ಲಿ ತಟ್ಟೇವೆ ಆಯ್ತಾ ಸೊಂಟದಲ್ಲಿ ಒಂಚೂರು ನೋವಾಗ್ಬೋದು ಕಾಲಿಗೆ ನೋವು ಅಂದ್ರೆ ಹೇಳಿ ಜಾಸ್ತಿ ನೋವು ಆಗೋದಿಲ್ಲ ಸೊಂಟ ಅಲಾಡಿಸ್ಬೇಡಿ ಅಷ್ಟೇ So this was the step I was mentioning. Ready? Sir. Okay, now you can see I am on the post vertebral line. I am going to hammer it into the disc space. Aita, ready? Shoot. Shoot. Maybe. So beautiful anesthesia. Yes, thank you. So we didn't have even
Then see the annulus.
Yes.
And then the epidural space.
Exactly. Because this is avascular, so it's always better to deal with this area first. So as we come to epidural, there could be, we can see some bleeding, but this area is totally avascular.
Here and even the space might have got collapsed.
Here, I mean, in the MRI also, it doesn't show much of a soft disc fragment. It's more of a chronic annular disc. We have had a small disc fragment there, but I don't see a big fragment. I don't expect a very big fragment here. Even this is all empty. But then as we come out, it's more of a chronic disc. So you find more layers of annulus. I'm trying to shrink all these tissues. This is a 4 megahertz radio frequency cautery, so we call it a cold cautery. So I'm trying to come out with my cannula. The lights also correct ಮಾಡ್ತಾ ತುಂಬಾ glare ಇದೆ.
Once the disc material is removed, do you think that the cannula is jammed between the two vertebrae?
Sorry sir, please come again.
Once the disc material is removed, so does the vertebral body jam the sheath? That's why you are feeling more difficult to remove it from there.
Sorry, I am unable to hear you clearly. Sir.
Is the sheath wedged between the vertebrae so
The light try ಮಾಡಿ ಸರ್.
difficult?
ತುಂಬಾ glare ಇದೆ. Yeah, ಸ್ವಲ್ಪ right. I mean, just because we remove some disc material, the space will not collapse. I mean, it was not a very big fragment as such, it was tiny fragments only. Next one. That is it. Who found the remote? Sir. So what I'm trying to do here is use the hook to tease out the tissue here. Comrade one, which is clapping. Okay, that's enough.
Okay.
Okay?
Okay.
Now you can see that clapping, if you put oozing from that area, that's another. The entire thing is another.
So is it possible to probe it? So going posterior or anterior to the root?
Sorry?
With a probe, can we?
Yeah, try.
Is it possible from posterior and anterior part of the root?
No, we cannot show you
We
the
cannot show.
posterior part because it is, will be, the facet will come in between. I can try to show the anterior part.
The probe going in front of the root.
Yeah. I'm trying to push the structures away, but I feel there are other. Yeah, we are not doing anything. There's a nerve root there, position of nerve root, what you see. Okay? Sorry?
Bone wax applicators to
No, sir.
test probe.
No, this will, the oozing will stop. It won't be very big because it's magnification. That's why you think that, there's a lot of bleeding there, but it's hardly. So, this is like
Excellent demonstration of Transforaminal endoscopic discectomy. Thank you all the OT team, thank you Netra sister, and thank you Dr. Darshan and team for giving the wonderful anesthesia for this CME program. Thank you sir, thank you very much. Please give a round of applause to Dr. Rajiv sir. Now I request Dr. Yogesh to give valedictory.
Youngsters to do things, he never says no to things, he encourages us. So a very big round of applause to Maruti sir.
He is an experienced person, and the other side the young energy guns. So both we have included, and me and our Dean and Director, and all the presidents of our associations, we have just encouraged it, that's all. But everything is done by you people, okay? For us, okay? To gain knowledge by us, and we have done all these things, and we will make ourselves update with this knowledge, and we will use this one for the betterment of mankind from today or tomorrow onwards. Thank you for coming to us. And Chikmagalur, Mysore, from various places, and our speakers also came from Chennai and Bangalore and Bangalore as well as from the Mysore. So everyone contributed for this one. Any feedback from any audience?
Hello.
So as a teacher and as the seniors, this is small moment. Please keep all these things with you as good memories. And thank you everyone from Department of Orthopaedics for from morning you have been here with us, and yesterday day before yesterday also you were with us for the rehearsals.
Don't be shaken, come in.
Kirana.
Madhu. What ba? Bega. The CRM technician has done very wonderful work for all three cases. Thank you from the Department of Orthopaedics, Madhu.
ಫೋನಲ್ಲಿ ನನ್ನ ಜೋಬಲ್ಲಿ ಫೋನ್ ಐತಲ್ಲ ಸರ್ ರೆಡಿ ಹಲೋ ಸ್ಮೈಲ್ ಒಂದು ಸೆಕೆಂಡ್ ಎರಕಳು ನನ್ನ ಜೋಬಲ್ಲಿ ಒಂದು ಫೋನ್ ಐತೆ ಕೇಳೋಣ
ಅವ್ರಿಗೇನು ಕಷ್ಟ ಆಗಿಲ್ಲ
ಸರ್ ಥ್ಯಾಂಕ್ ಯು ಒಂದು ಸೆಕೆಂಡ್ ಸರ್ ಥ್ಯಾಂಕ್ ಯು